Okay, wonderful. So good afternoon, everyone. Welcome to the first of our four-part webinar series, Championing Best Health, the primary care series on pediatric obesity, hosted by our Office of Lifelong Learning and Physician Learning Program here at the University of Alberta. My name is Denise Campbell-Sher. I'm the Associate Dean of the office. The Physician Learning Program and the Office of Lifelong Learning are committed to providing reliable updates and resources for clinicians, healthcare professionals, and everyone committed to providing best clinical care for patients. I'd like to acknowledge, especially this week, a very important week, that the University of Alberta, its buildings, labs, and research stations are primarily located on the territory of Nihao, Niitsitapi, Métis, Nakota, Dene, Haudenosaunee, Anishinaabe lands that are now known as part of Treaties 6, 7, and 8 and the homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So just a little bit of housekeeping information for our webinar today. I'd like to just highlight that if you have a question for the speakers, please use the Q&A feature on the bottom of the screen and have a look at what has already been asked and upvote questions you'd really like to have answered. We can't guarantee that the panelists will be able to address all questions. For the chat feature, that's just if you have technical difficulties or challenges where you or questions about L3 programs or services. A recording of the webinar will be sent via email to all of those that registered. And participants can claim CME credits and complete a personal development activity using the My Lifelong Learning Plan tool or through the linking learning exercise for Main Pro Plus participants. This activity has not been formally reviewed by the CFPC or Royal College, but it is eligible as well for non-certified credits. So today, we're very pleased to welcome Dr. Stasia Hadjiyannakis and Dr. Laurie Clark, who will be presenting on starting the conversation, talking about weight with kids and families. Stasia is a pediatric endocrinologist and the medical director of CHEO's Center for Healthy Active Living. She's an associate professor of pediatrics at the University of Ottawa and has been an active member of the Department of Pediatrics at CHEO and the Division of Endocrinology since 2002. Her clinical advocacy and research interests are in the area of pediatric obesity assessment and management, with a focus on the development and evaluation of clinical tools, such as the 5 A's of pediatric obesity management and the Edmonton Obesity Staging System for Pediatrics. Laurie Clark is a clinical psychologist and clinical investigator with the Center for Healthy Active Living, CHAL, at the Children's Hospital of Eastern Ontario, where she works with an interdisciplinary team to help children, youth, and their families achieve their best health. Her areas of clinical expertise include pediatric obesity, eating disorders, and body image difficulties. Laurie has contributed to the development of key clinical tools, such as the 5 A's of pediatric weight management and the Edmonton Obesity Staging System for Pediatrics, so the EOSP, and is actively involved in clinical research and program evaluation. And so it's just wonderful to have both of you join us today for the kicking off this series. Thank you so much. I will turn it over to you.
Thank you for having us and for those spending their lunch hour or taking time from their day. Just bear with me while I hopefully share my slides properly. Stasia, does that look right to you? Or can anybody tell me if it looks right?
Perfect.
Perfect. Okay. So I'm just going to get going here. Why does it not want to? Oh, there we go. So here are disclosures. Oh, no, you can't see them yet, can you? That we have. And this is part of a four-part series on pediatric obesity. So today we want to talk about how to start the conversation and talk a little bit about the new guidelines that came out. I think both Stasia and myself are fairly passionate about sort of trying to combat weight bias and stigma, to help our patients and families feel more comfortable and own themselves within the world. But others say it much better than we do oftentimes, and have more powerful voices, I think, in these areas. So we just want to, echo some of these sentiments that everybody is worthy of care and intervention when it's in trouble, and no body is taking up too much space. I'm going to let Stasia take over from here for a few slides.
So I think all this really to recognize the complexity of obesity, biologically, sociobiologically, and that not all obesity is the same, and a recognition of the chronicity, the progressive nature, and the often times a feeling of resistance to treatment that we encounter when assessing and managing obesity with our patients and families, and just to acknowledge the recognition of this by multiple medical associations. Next slide. Traditionally, obesity has been defined using anthropometric measures, but we know that the definition is has its weaknesses, and we'll get into more of that, I think, in the next session. But we do still use body mass index as a starting point in our pediatric assessments. And so next slide, Laurie. So in pediatric assessment, we start with sort of understanding when to take those next steps around the assessment of obesity. We still do rely on our BMI growth curves, and depending on the growth curves that you're using, you could either use your CDC growth curves or your WHO growth curves. And if you are seeing a young person with a body mass index above the 95th percentile on a CDC growth curve or above the 97th percentile on your WHO growth curves, that could be an indicator to you that maybe it may be time to sort of have a conversation or begin an assessment to assess whether there are any weight-related health issues or anything that might be driving weight gain for your young patient. Next slide. We also, similarly to adults, have a BMI classification system where we define severity in terms of BMI class based on BMI percentiles or Z scores, where class 2 and class 3 obesity are defined as severe obesity. We don't use terminology like morbid obesity any longer. That terminology has been retired, so we can talk about a young person who may have class 1, class 2, class 3 obesity, or severe obesity if they have class 2 or higher. And in your EMRs, you could, next slide, Laurie, you could potentially incorporate an expanded BMI curve. And I encourage you to do that. So there are some limitations to the non-expanded version of the BMI curve in terms of really being able to look at historical data in a meaningful way. And from my perspective as an endocrinologist, the historical data can be really telling, those various points where there may be an inflection point, a change in trajectory, maybe an indicator to you that might be a key area in your history taking to kind of find out what was happening for the young person physically, from a health perspective, developmental health perspective, socially, within the family. That might help you understand the changes that were happening at that time. It's not necessarily something that I show the patient or the family, but it's something that I use to kind of help guide my history taking sometimes in terms of trying to find out where things, what things might have changed for the young person during those time periods. Next slide. But again, I know we'll get into this next session as well. BMI is really just a marker of body size, and our body shape and size is largely genetically determined. So some of us are born with a genetic vulnerability to having a higher body weight, in the same way that some of us are born with a genetic, makeup to be taller. And so a lot of that risk comes from our genes, and then there are, of course, epigenetic changes that can either exploit that risk, turn on or turn off certain genes that leave us more vulnerable to gain weight more easily. And the reason I bring this up to this session in particular is I think as we think about having these conversations with young people, I think there remains a belief, an overestimation of the individual control that we have over our body weight and our body shape and our body size. No, more so than we ever think about, we have control over our height. Nobody comes in feeling guilty that they're not as tall as maybe they wanted to be. So I think important as clinicians that as we walk into the room, to meet with young people and families who are living with obesity, that we also fully recognize what body size means, what it doesn't mean, and what and that weight is beyond individual control, and that we should never have any guilt or shame over our body shape or size, nor should we have any guilt or shame over our children's body shape or size. So I think understanding the genetics is an important piece of that, and sharing some of that information with our patients and families. Next slide, Laurie. And then, of course, I know many of you are aware, like once body weight is gained, or our body defends very strongly against weight loss. There are strong neuroendocrine mechanisms that work to sustain our body weight and to respond to weight loss in a way that increases appetite, decreases energy expenditure, all in an effort to regain any weight that was lost. And of course, not everybody or every child living at a higher body weight at all needs to lose weight to be healthier. We have health across a wide range of body shapes and sizes. But I think understanding the neuroendocrinology and the genetics of body weight regulation can really help us understand expectations when it comes to interventions. And so important for us as clinicians to be aware of the science. Next slide. As many of you know, there were the new guidelines that were published in April of this year. So if this is an area of interest, then I would encourage you to have a glance at the guidelines if you haven't already. They were really meant to be, they were updated after a long period of time to try and incorporate some of the new and available interventions and tools that we have to help support children living with obesity. And the change in the way we sort of think about management. Traditionally, we've always said, okay, well, you try lifestyle first, and then maybe pharmacotherapy, and then potentially surgery. But really, instead, really looking at all the interventions, the risks, the benefits, and really taking a more a personalized approach to what we're recommending based on the health risk of the young person that we're seeing. Next slide. So within the guidelines, you'll get a chance to kind of see a really evidence-based evaluation of the different interventions that are available, which we'll get into in future sessions. But just to give you a sense of where the recommendations are coming from in those guidelines. Next slide.
Okay, so we sort of, instead of just listing all the long points that are in the article, or in the guidelines, we sort of think they summarize quite well into 4 areas, or good practice statements to guide sort of the ethos of how you're going about your work with children and families. And so one of them is that we do recognize obesity as a complex, chronic, and relapsing disease that requires long-term support. And we want to, within that, consider the social determinants of health, which we'll talk about, we factor into our assessment. And the second sort of piece of the pie we need to think about is establishing a positive relationship with the children, teens, and families. And I know that in primary care or in family practice, we're often you have limited time, and you don't have maybe the luxury of the multidisciplinary team like we do. But one of the things that I think is found sort of in many settings is that taking a few minutes at the start of a relationship with patients to sort of establish some good rapport, particularly with maybe teens who don't want to say too much or have, you're getting your grunts or your one-word answers, is really trying to take a few minutes to establish some rapport with them at the outset, because it usually makes things go faster later on. So we want to use person-first language, and I'll talk about that in a minute. We want to sort of be aware of any biases we have around weight and health and what that means, because I think, although teens might not say too much to us, they can kind of read on our faces and from our body language what we think about certain things. And so we really want to try to have a non-judgmental approach and a curious approach to what's happening for them. We need to recognize that there is a power imbalance, and for different cultures and families, this may come out differently in terms of whether or not you are the expert and you should tell them or their children exactly what to do, or whether or not they see the sort of power relationship a bit different. But oftentimes we need to recognize that if we don't sort of take into account that they may see us as the expert or the one holding, the cards to different treatments or services, that they may feel unheard. We need to recognize that weight stigma and bias is very present and real within our society. It's real for kids within schools, within even higher education systems, in the workplace, and definitely within healthcare. And so we need to create a safe space when we're talking about these things. And then the last point is we need to sort of discuss expectations with our patients early on in terms of what they expect the outcomes of their efforts to be, and make sure they're realistic, that they're not thinking that they're going to lose 40% of their body weight quickly, things like that. The third piece of the pie is that it does need to be collaborative care, the multidisciplinary team approach when available, but we'll also talk in the third session about how to sort of strategize and use the other services in your community to kind of make sure that needs are being met. Considering access to resources, including healthcare, food, financially to be able to access activities, but also time is a big one for a lot of families to do all these things we're asking them to do. And we need to make sure that our interventions are that we're presenting to the families, we're giving them, we're giving them an overview of what's available. And it's based on evidence, feasibility, and what's available to them. And then we want to complete a comprehensive assessment. The guidelines really spell this out in terms of using appropriate tools to move beyond BMI, and to engage families in a collaborative approach that's sort of long-term. So Stasia, do you want to present the case study? So we wanted to present a bit of a case that we're going to pull through all 4 weeks. So we're going to present it to you now before we get into this, the first the 5 A's and how we talk about these things. Yeah.
Yeah, so we met Alex. He's an almost 13-year-old boy. He comes in with class 2 obesity based on body mass index. He has a few risk factors for having obesity, including a large birth weight. He had a history of being a bit colicky as a baby with reflux, and there was there was some soothing. Food was soothing at that time, and so that there may be something there. He's tall, which we often see. He has a normal growth velocity, no neurodevelopmental concerns, and he's always been a bigger young person. Like, he's always been taller and had a higher body weight than his peers, but there was a more rapid weight gain following the separation of his parents, and also around the time of COVID. Next slide, Laurie. And then this is his growth velocity. So you can see he's quite tall. This is not unusual for the patients that we see. And then the next slide. And then this is his expanded BMI curve. And you can see we only had 2 points, but he's got class 2 obesity based on BMI. And he has crossed upward a little over the year and a half in between those 2 points. So his trajectory is not quite parallel to the curve, which may suggest there may be some drivers there for him right now.
Yeah. Okay, so we've got Alex coming to see us. So we are gonna sort of ground our work with Alex within a 5 A's framework. So, and this comes from the 5 A's of pediatric obesity management. The 5 A's, I think, is fairly well known and there's lots of variations within obesity management for pregnancy, for primary care. And so the pediatric version is similar with some sort of added caveats to take into account the fact that, we've got young people here who may not be able to understand all the intricacies and how to work with families. So many of you will have during your training or afterwards learned about motivational interviewing as a way of helping to move people towards change. And if you haven't had any experience with motivational interviewing, I would recommend it in terms of helping you to frame discussions and questions in ways that can kind of move people from maybe not being interested in making health behavior changes or moving them along that path. And then how do you work with people at different stages of readiness for change? So again, being respectful, we're going to start by asking permission, because typically if we ask permission, most of the time people say no, even kids and teens. If you say, could I talk to you about your health, or could I talk to you about something that I've noticed in your growth? Usually people will say yes. We know that weight can be a sensitive issue for many children and parents. We know that oftentimes children who are living in a bigger body often have experienced teasing or bullying. Parents who may themselves, because of genetics that we've just talked about, also had experience of being a larger kid and continuing maybe to live in a larger body. And so they've had their own experiences with weight bias and stigma, even from healthcare professionals who've maybe not listened to the reason they've come in for the appointment and gone straight to discuss weight, or made assumptions about how they're living. And so when you walk into the room, you're kind of going up against all their past experiences around the subject. And so to keep that in mind. And so we want to ask permission first before we kind of delve into things. I think I've already talked about, being mindful of your own biases around weight and health. Um, can, if maybe asking yourself some questions. Do you think somebody can be healthy if they're living at a higher weight? Um, do you think that weight loss is always, um, the best uh, course for somebody's health, in terms of attractiveness, all of those sorts of things. So we need to be aware of our own biases. We need to think about our facilities, and we're going to talk about that in the next slide, and the language we use. The other piece is, it is a sensitive subject, and so thinking about if you have adequate amount of time to address the issue and listen to your patient, is this the right time or the right visit, or do you make a note to yourself to sort of raise it earlier in the next appointment? So in terms of our creating a weight-friendly practice, I know, we're all kind of working oftentimes in buildings and things that we're making do in lots of ways in healthcare these days. And so while you may not be able to make structural changes to your facilities, thinking about just maybe what it's like for folks moving around in our hospitals and clinics. Restrooms, are they large enough to move around easily? Do your scales and your blood pressure cuffs and gowns, will they fit a wide range of folks? What kind of chairs do you have in your waiting room? Less so about the reading material. After COVID, we don't see a lot of magazines and reading material in our waiting rooms anymore. But just in terms of where people are being weighed, oftentimes the scale might be in a hallway or something where it's over. It can be, if it's read aloud, it's overheard by others. So thinking about how to be, sensitive to what it's like for our patients. So when we start asking, we talked about person first language. So talking about people living with obesity, people living in a larger body or at a higher weight, not obese people or big people. There's lots of places now, and there's been lots of research about what terms patients and families prefer. And sometimes we go with the language that, the family uses, particularly the kids use. The one caveat to that might be if they're being overly negative about themselves or parents are being negative about their child's weight, we're not going to use the same words that they use, like fat, morbidly obese, those types of things. So we want to think about the language we're using as well. And the ways we're talking about it in front of younger children, and I'll talk about that in a second. And I know that there were some questions submitted about when do we have these conversations with parents and kids separately. So maybe I'll just address that now. So when we talk with kids and families, if this is a family that you know well, you followed for many years, and you have the sense that they're not going to be really negative about their child's weight or make really harmful comments, you could have the conversation together. Remember that in terms of cognitive development, kids are pretty black and white, concrete thinking until, their frontal lobe starts to develop a little bit. They can see black and white in their thinking. So if we start to talk about weight and using negative terms with it, they will automatically sort of associate that being of a higher weight is bad. If you think that parents are going to be really negative or cruel about you're talking about their child's weight, then I would suggest you don't have the conversation with everybody together. With teenagers, I think it's a little bit easier because most people often spend some time alone with the teen. And so there is opportunity to sort of have a conversation with the teen first about, if they have concerns about their weight, or how they're feeling about it. But often times, if there is the opportunity, I think I would suggest you sort of ask parents separately, particularly if you don't know them very well. So we start really generally. So we want to start with I often think of, the triangle of you start wider and then you hone in, right? And so starting sort of more generally, and this is of course after you've sort of maybe addressed the issue they've come to you for initially, if it's not weight, or sort of a well-child visit, to say something like, do you have any concerns about your weight? And oftentimes I think we start with health. Do you have any concerns about your child's health? Do you have any concerns about their growth or their weight? And see kind of what comes out at that point. If they're saying, no, I was a bigger kid, and then I kind of leaned out over adolescence or whatnot, or he's like everybody else in my family, then again, we're going to ask permission, and we're going to say something like, would it be okay if I discuss with you what I've, noticed with their growth over the past few years, right? If you have a nice growth curve. If they say, yeah, I'm concerned about it, I don't know what to do, then you can ask, is there specific concerns? Usually what we see, I think Stasia would agree, we either get, the concerns tend to fall in one of two areas. It's physical health complications, or concerns about, things like type 2 diabetes, cardiac health, things like that. Or it's the psychosocial side of living in a bigger body in terms of peer acceptance, bullying, teasing, self-esteem, that sort of thing. And oftentimes we see that kids and parents have different concerns. So we're trying to kind of gather some information, help people feel comfortable. So we ask them what their concerns are. And then oftentimes, and Stasia does a great job of this, of asking if, their weight impacts them in any way. And really what we're sort of trying to get at is, are people treating them differently? Do they feel like people are treating them differently because of their weight and size? Are activities of daily living more challenging for them? Can they, play at recess and keep up with their friends? What do they see as an impact of their weight, if anything? So I think Stasia and I were going to do a little role play here, eh?
Yes, will you be Alex?
I will be Alex.
So we'll go back to our case. So if I could just give a little background, when I met Alex, and we've changed his name, when I met Alex, for me, it was the first time. So typically I would say welcome him to the clinic and say, it's because it's our very first visit together. I'm just going to ask you a few questions just to get to know you a little bit. And I typically start with sort of just getting to know their interests, like a little bit about school, the things that they're really interested in. And hopefully as family care providers, potentially you may already know that background. As Laurie said, patients do prefer to have these kinds of conversations with healthcare providers who they have a relationship with. So I think you're the perfect to have these conversations with your patients, and especially if that therapeutic so when I meet a patient for the first time, a lot of the work I do initially is to build that therapeutic bond, which may already exist for you. So if you already kind of have knowledge of this young person and what they're interested in, always see them as a person first. I find even just a few seconds on something that's something that they're interested in or something that's important to them is always a nice way to start. And then just generally, I will, as Laurie says, I'd say, so Alex, how are you doing today? It's great to see you. I was just wondering, do you have anything that you wanted to make sure we talked about today? Do you have any concerns or things that you wanted to share with me today?
No, my
Any
mom made me come.
Do you have any worries about your health? Anything that's been bothering you or you've been thinking about over the last while?
Well, yeah, sometimes my knees hurt.
Okay, can you tell me a little bit about that?
Well,
When,
like when I'm running a lot and like doing stuff at recess, sometimes I just feel like when I sit down in class after, like my knees really hurt.
yeah, does it stop you from doing some of the things that you want to be doing?
Yeah, sometimes I think, sometimes my dad wants me to help out with stuff around the house, like in the backyard, but I feel too tired at the end of the day and my knees hurt too much. So I kind of I kind of sneak into the basement and just avoid him.
All right. So it sounds like sounds like having some knee pain that's bothering you, that's kind of getting in the way of things at school, but also helping you to avoid doing some things with that. It sounds like,
Yeah,
yeah. All right. And do you have any thoughts on why you might be experiencing this knee pain?
I don't know. Um, I think it kind of like, I don't know, I used to not have it.
Yeah. And has anything else changed for you over the time between when you ha didn't have the knee pain and now?
Well, my dad says it's because I'm fat.
Oh, I'm so okay. How does that feel when Dad says that?
Well, I don't know what he's talking about because he's bigger than I am.
Do you have any worries about your body weight? Is that something that you think about or worry about?
No, I mean, I think it's fine.
Do you feel, how do you feel when Dad mentioned that? Like, was it something that you thought about before Dad would say something like that, or were you kind of pretty shocked when you heard Dad say that to you?
Well, I mean, like, look at me. Like, of
Oh.
course, I know I'm bigger. I mean, everybody points it out.
Have other people made negative comments about your body weight?
Did you go to middle school?
Right. I'm sorry that yeah. So it's been pretty hard.
I mean, there's just a few kids that are
Does it
kind of
ever,
jerks.
does it ever make you not want to go to school or kind of avoid going to school?
Are you gonna tell my dad this or my mom?
No, this is just between the two of us.
Well, sometimes I try to skip gym day because, like, the teacher's pretty mean, and if I say my knees hurt, he just says that I need to run more.
Right. Right. So sometimes things feel physically harder for you to do, so you might try and avoid them. Yeah. And
And
then
I'm always like, nobody wants me on their team.
then how does that make you feel?
Not good. Would you feel good?
No, you're absolutely right. Yeah. Would you like does does it affect how comfortable you feel in other areas? Or are there areas of your life where you do feel comfortable and good?
Well, I'm really good at like I don't really have to try much in school. I don't really do homework and it's fine.
Right, so super bright. Yeah. Successful. Successful in that area of your life.
I guess.
Well, would would you like would it be okay if we kind of took a look at both your knee and kind of got you a bit of help and increase comfort with your knee, try to figure out what's going on with your knee so it doesn't get in the way of things that you may want to do? And at the same time, maybe just complete an assessment to see how your body's doing and whether your body weight is something that we need to kind of worry about and see how your body's feeling. We know that healthy, strong bodies come in all shapes and sizes, but at the same time, we also know that it might cause some health issues. Would you be open to kind of exploring that with me?
Well, my mom says I have to, so I guess, yeah.
All right. Thank you, Alex.
And we did not rehearse this, so I was really mean to Stash.
I lost my footing. Sometimes, no, that was great, Laurie. As sometimes I also think I might have missed stuff. Like I think sometimes uh, finding out in what way their body weight is getting in the way for them is really important, and what, if anything, they feel would change if their body weight was different. Sometimes that's a really interesting question to ask, and also I think Laurie's taught me, like, are there things about your body that you really like, and are there things that your body can do that you're really proud of, and are there things about you that you're really proud of, especially if they're speaking negatively about themselves. Try to kind of counter some of that negative thought. But I know I'm conscious of the time, and we really love an opportunity to hear from the audience in terms of questions or challenges that they've had, as demonstrated today. Some of the challenges I had in having the interview with Alex today. I know these conversations are not easy, but I think if you remain curious and humble, or I think kids really do see that, and I do believe they want a safe, open space to talk about these experiences that they're having. That was a really tough thing to hear, Laurie, when you said that Dad. For me, it just kind of caught me when you said that Dad made those comments to Alex. So yeah, I don't know if others have feel like they are comfortable sharing experiences or have questions that they might want to ask.
Thanks so much, guys. Yeah, so we can open it up. I think in the background we do have Natasha. If people either want to type it into the Q&A, or if you want to come off mute and talk about your experiences. Maybe just while we're waiting people to gather their thoughts and pose a couple questions, I might share one. How do you handle it? Sometimes the parents might be suffering with obesity and had a long-standing history perhaps of bullying or things like that that kind of came up in your case that you gave. And more than anything, I think parents just want to try to spare their kids suffering. Yeah. And so when you get into this and you start to kind of come into maybe unresolved things for the parent, how do you handle that yourselves therapeutically in the space? And can that also be therapeutic for the child? Like, how do you use it?
Yeah, I think, and I know that, I often have more time with, families if I'm seeing them for therapy and things. But one of the things sometimes if we have a parent who's really sort of weight focused and just keep saying, but they're, we've been here for 6 months and they're not losing weight. They're still, look at their belly kind of thing. If I have the opportunity to talk with parents alone, I will ask them sort of, again, review. So you seem really concerned about Alex's weight. What is it that most concerns you? And then sort of try to move them to an understanding of, if they say things like, I remember when I was young and it was terrible, or, there's been teasing at school for Alex, I need it to stop. And if he just lost some weight, I think it would stop. And to say, yes, that's true. But, or on the other hand, we need, we don't want to give him the message that he needs to change himself because somebody else is bullying him, right? And so and then asking parents what it would have been like if their parents were mean sometimes, like what was that like for you if your parents were always on you about your weight or dieting, because really we want to move them to the idea that you're right, someone, you've had your own experience, but you actually, what's best probably for your kid is for home to be a safe space where they don't feel like they're being criticized or told they're not good enough because of their weight. And usually parents can see like, yes, okay, that is something, I understand that home should be a safe place where they're not being teased about this stuff or bugged about it. And so this is, while we work at this, mom and dad, we need, comments about, food choices and things to sort of stop, because it's actually doing the opposite of what I think you're trying to do.
I also think that yeah, I think with if I think back to the assessment that I had this week with Alex, he he also shared, we hear from both patients and families, parents, sorry, from both patients and parents, probably the most common concern that they have is the social piece and social connectedness and feeling socially comfortable and confident. And the young man this week, he was able to really express that and said, yeah, my feelings about my weight do impact how socially comfortable I am. And then I know Laurie does this beautifully. Like, well, how would you feel if, as we work on things around weight management, could we also work on just helping you to feel socially comfortable and confident? Because it may not be that you need to, like, it doesn't mean that you need to, we can help build some of that resiliency, some of those skills around social confidence and comfort and navigating situations of bullying, or even advocating against those things. Because as it doesn't matter, that those feelings of social comfort cross BMI, like cross all kinds of differences amongst human beings. So yes, weight is one, and it's been in, one that's kind of continued and is so persistent and hard to change. But of course there are other areas. So we really need to help build that social confidence and comfort as well, and see some of the things that will help, of course, in managing your physical and mental health will come from also helping you feel worthy and engaged, and not not wanting to hide away. Yeah. And we also need to advocate for those safe spaces so the bullying doesn't happen. But absolutely, Denise, I think the most common thing we hear from parents is I don't want my young person to experience what I did growing up in school, and the bullying that I experienced. Yeah.
No, very helpful. Thank you.
I think from a provider piece too, sometimes we kind of cringe inside when parents say really hurtful things. And thinking about it as, this is a parent, like their mama bear, papa bear has come out. They just want to protect their kid from any sort of hurt or pain, right? So they want to protect them from being bullied or teased. They want to protect them from any, health related complications. And it's just the way that they think they're going to get there is maybe, not really what it's doing.
Mm-hmm. Okay, great. Well, we have a couple questions in the Q&A, so folks, don't be shy. Put your questions in. But the first one is from an anonymous attendee, which is, what if a patient decides to go on a restrictive diet and one parent allows them to do it with no concerns for the health consequences and doesn't cooperate with the doctor who sends for nutrition assessment, referral to peds, etc.? Yeah, so unevidence-based problematic courses of treatment in this age group. How do you approach that?
So this is where, yes, the two different households, we see this often, have very, oh, I'm sorry. Stasia, do you want to handle this since
Yeah,
you're not in the hospital?
I find that my approach to this has changed over the years, in terms of how quickly I will kind of react. Like in the past, I think I would sort of, instead of staying curious, I would share information. But I think now my approach is really to stay curious about, tell me a little bit more about how you came to this information, this diet, and why this particular diet, and what are you trying to, what are your goals with this approach? And then as I hear more about where that motivation is coming from, what they're looking for, like let them kind of share how they came to this decision to try this restrictive diet. Then I would also share that we have shared goals when of course, like when caring for their young person. And would it be okay if I shared some of my concerns or what I know of the course of things when the impact of restrictive diets sort of metabolically? Would it be okay if I shared a few things with you, and maybe we could come to some kind of compromise? So primarily for me, I want to hear what their goals are, and maybe we can reach the goals that they're looking for in a way that's healthy and protective of the young person, which is what they want, I think. And maybe aren't always aware of potentially the risk of restrictive diets, which is not only metabolically, but of course, vulnerability to binge eating, emotional eating, to secretive eating, things, and increased weight over time. So would it be, to sort of share that information, but not share it immediately? Like I usually like to, not sort of, because I worry, in my experience, at least over the years, it's been, if I've done that, then they may not come back, or they do the diet anyway, and they don't come back for follow-up. And so I feel like the young person is put at greater risk if I don't sort of engage in the conversation in a more open way, at least hear them out, and then see if we can come to a path toward their goals. That's one that's medically safe and evidence-based.
Nice, thank you. Okay, and then Nandini has a question here around, do you discuss what success looks like to the child and to the parents? When is a good time to bring that up? How do you move forward if both have different expectations?
Good. So often we do talk about, I think, sort of fairly early on. Again, it's going back to the what the new guidelines have suggested as good practice statements, is discussing what expectations are, because we don't want kids to set it on this path, or parents, and they're expecting a 10 or 15% drop in weight from lifestyle change, because they may improve their health, but if the weight doesn't change, they're going to see it as a failure and give up everything, right? And so usually, if kids will often say, well, I still want to get down to a size 12 for prom. The number of times I've heard that, astonishing to me, and yet not. So I say, okay, so I get that that's your goal. I'm a little concerned that that's a big change. Can we again, the share goals, we both agree that some of the things that might help you feel better in your body and help your health is to do, these things that we have control over, our behaviors. Could we agree to try that? And oftentimes I will talk with kids, like, and with parents privately when kids aren't with me, say, so let's say we do all these things and their health is better, and I could look into a crystal ball and say their health is going to be great. They're not going to, and they're going to have good body esteem. Would you be okay if this were their weight or their size for the rest of their life? Right. And if parents say yes, I said, okay, so let's work on the health then. If kids say, no, I need to lose weight, then we're going back to, okay, so, you know, talking about that more, what it means and why they want to lose the weight. And oftentimes they think everything would be perfect, and everything is because of their weight. And so talking about that a little more in depth. If you're in doubt about which goals to move forward with or which kinds of things, we always side with the kiddo, because if they're not on board, especially the teenagers, we're not getting anywhere, right? They'll say yeah, and then they go out and they do their own thing. And we need to establish the connection with them. They're the harder ones to sell on things usually.
Mm-hmm.
I've also noticed, like, of late, and I don't know if it's like it just happened, but when I ask parents what their main concerns are, or what their main goals are for the young people that we're seeing, many of them, are saying, I just want them to be happy and healthy, right? And that's their goal. And that doesn't necessarily mean they need to lose weight necessarily. Maybe for some, their body weight is causing significant health issues. But I think ultimately what the parents want, at least the parents want happy and healthy kids that feel that are living fully in the world, that and not holding back. And I think that young person who wants to be in a particular size, if we could make that young person feel beautiful and comfortable and find a beautiful dress in any, in whatever size is most suitable for her, I think it doesn't necessarily have to be that number of size 12, And so how do we get her to that place where she can go into a store and feel comfortable shopping for that prom dress and not worrying about the fact that it's not the size that she sort of has in her mind as the perfect size for her, or the goal size.
Mm-hmm.
But ultimately, I really do think, and if we could work like really clearly not conflating size and health, I think that would also help, because sometimes people think, well, she can't possibly be healthy at this size, and so we have to undo some of that, because the truth is some of the young people I see are quite healthy at their size, and some kids with much lower body mass index have a number of metabolic health issues or other issues. So that conflation of health and size, I think, also is something we need to work at undoing.
Wonderful. Well, listen, I'm mindful of time. I'm just gonna actually, we have a nice comment in the Q&A from Isel, which is just really echoing, I think, a lot of what you just said, Stasia. I do want to just, before we go to the evaluation slide, just want to highlight this slide here. I'm not sure if people noticed it, but this is a tremendous toolkit. And just really encourage people. We'll make sure that in the materials that we send out to you with the recording, that we highlight this link as well. Really encourage people to have a look at it. It's excellent.
Yes, Dr. Amy McPherson. I want to shout out.
Yes, Dr. Amy
McPherson.
McPherson, a wonderful colleague of ours from the Obesity Education Coalition, who's really pioneered this. So very, very, very helpful. So Natasha is going to put up the evaluation slide just so that folks could please give us a little bit of feedback for Stasia and Laurie on this session today. Just really want to thank both of you for kicking off this series of 4, and we come together again next week. And what's the topic next week?
We're going to do the second A, which is the assessment. So going through some of the tools you can use to assess all aspects of health, and then talking about both the mental, metabolic health, biomechanical health, what you need to do for that, and what we're looking for at different ages.
Wonderful. Well, really, really looking forward to it. Thank you so much, folks. And everybody who's in clinic, have a good clinic this afternoon. And thanks so much for giving us some great tools to help us with our pediatric patients.